You're the director of BTAR, right?
Yes.
So tell me a little bit about this facility. What do you do there? Why do people go there?
Okay. So the facility opened in 2000, January of 2000. So, we're actually approaching our 25th anniversary of being open.
And I'm not but 27. I just don't know how that works.
Yeah, time flies for many people that have lived in the community. I remember when Hurricane Floyd came through in 1999.
Oh, I was at the ER then.
And,
yes, sir.
And BTAR was under construction at that point. So we went to work that day, and I remember being on campus, and I will say stuck, because we literally came to work and we were on campus for about 3 or 4 days that we couldn't leave because the water had risen.
That's right.
And I remember we spent a lot of time walking through BTAR because it was under construction and we didn't really have a lot to do on campus. So, yeah. But for the facility, BTAR is an acute rehabilitation hospital. So where that fits into the continuum of care is many times when patients are admitted to the hospital, it's because of a traumatic life event. It could be a stroke, it could be a surgery, it could be a trauma. Patients are in the hospital for several days and they're just not quite ready to go home. They really need some extra physical rehabilitation to get them to the point that they can make that safe transition from the hospital to their home setting. So that's really where BTAR fits into the healthcare model. From a facility standpoint, we have 23 beds. It's a very spacious 45,000 square foot facility.
It's a beautiful facility.
It's really unique for Nash that we actually have a freestanding inpatient rehab hospital. Many hospitals that have rehab programs, they occupy a floor of the main hospital.
That's right.
And it was really Mr. Aldridge's vision that when the facility was built, he wanted to make sure that the patients felt like they were leaving the hospital, making progress. Mm-hmm. So they're leaving the acute care hospital and they're heading into a rehab program where they're leaving one setting and really transitioning to another setting to try to get back to that safe home setting. So as far as the team we have at the rehab hospital, we have physical, occupational, and speech therapy. Mm-hmm. We have recreational therapy. We have a licensed medical social worker. We have a team of rehabilitation nurses that are highly specialized to help with the rehab program and help with that, safe transition for the patients that they're making. So, yeah.
It's awesome. It's really a beautiful facility.
Yeah. And Rocky Mount's really fortunate because there's 109 acute care hospitals in the state of North Carolina. There's 27 inpatient rehab programs in the state of North Carolina. So this is definitely not a service that every hospital has. Right. And there's really not even another inpatient rehab program within about 45 minutes of Nash.
I never knew that. That's interesting. Yeah.
So,
for this being a little community, we really have it going on with the medicine, and with UNC coming and helping and taking over. I think our cardiology department is top notch.
Yes.
I tell my patients all the time, where would you go? I would go to Nash. Mm-hmm. I wouldn't have to go to Duke or Wake or, I think we've got it. And obviously we got the rehab too.
That's right. No, Nash in the last 30 years for me has really made a big transition from being, an acute care hospital with some outpatient services to really evolving our emergency medicine services, our cardiology, our surgical services.
Yes.
We have a great psychiatric program in Coastal Plain Hospital.
That's right.
And we've really done well with the surgeons that we have, general surgery and orthopedic surgery and neurosurgery. So Nash has evolved from a community hospital to be a place that people can really be proud of receive health care close to home.
Yep, you're right. They have multiple services. So is there any kind of a special accreditation that Bryant T. Aldridge has to have?
Yeah, so the hospital, including BTAR, are accredited by the Joint Commission. They come in, they visit hospitals every 3 years, and they do their accreditation survey. We electively pursue a separate rehab accreditation called CARF. It's the Commission on Accreditation for Rehab Facilities. And that for a rehab program is really the highest level of certification that you can
Okay.
achieve being an inpatient rehab program. And we're accredited for medical rehabilitation, and we're also accredited as a stroke specialty program.
Oh, are you?
Yes, and we've got Tabitha Jackson and Lauren Bunn that are going to be talking a little bit about
Okay.
our stroke program, and I know they're super excited to,
Yeah,
share
yeah,
that information with
yeah.
everybody.
Yeah, it's, that's, can be such a devastating
can be.
disease process. So, for us to have the rehab and get people back, it's just
Yeah.
awesome.
Yeah.
The only problem is, Brian, there's not enough beds.
True.
You've heard that
Yes,
before, I'm
that's-
sure.
That's right. Yeah.
Because the only other option, at least it was when I worked in case management, was nursing homes have a wing dedicated for rehab, and I'm not sure of the comparison. We don't have to do that, but
I think it's an important thing. I'd be happy to share
Oh,
that
okay,
information
sure.
with you. So, being a rehab hospital, one of the things that makes us unique is really the high level of care that's provided. It's really hospital level of care versus
Yes.
just being an inpatient
Yes.
facility.
Right.
So, the services that we have readily available to us are immediate access to lab work, radiology, all the imaging services, dialysis. If patients need to have procedures or surgery, those are things that can be arranged while they're an inpatient at our hospital.
Okay.
The patients need to come to our facility 3 hours of therapy at least 5 days a week. And oftentimes the patients will receive additional therapy on the weekends
Right.
as well. They have to have the need to see a physician specializing
I was just gonna talk about that.
in rehab care.
Yeah.
And they really need to have to see, have access to rehabilitation nursing, which is a really big part of our program as
Right.
well. On the flip side, for when patients are going to a nursing home, the still very good care. The intensity of the services for therapy isn't as stringent as it is for a rehab hospital. So the patients would not be receiving 3 hours of therapy a day. They wouldn't necessarily be needing to see a physician, so their medical conditions may be such that they don't need to see a physician every day.
Right.
And the level of rehab nursing is very different than what we would experience at a rehab hospital as well.
Yeah, and I'm sure this is still in place. When I was in case management, you had a liaison, a nurse liaison that would come from Bryant T. Aldridge Rehab
Yeah.
to, I'd call and say, it was Terry Glover at that time, I'm
Yeah.
not sure who's doing it
Yeah.
now. And I'd say, Terry, I've got patient X in room 3,
Yes.
And then she'd come and she'd give the yay or the nay, and based on the criteria that you all have.
Yeah.
So, and I think it's awesome that there's a doctor right there
Yes.
for the patient, and you don't have that in the nursing home, I know that.
Yeah, and we're really fortunate. Dr. Bryan is our medical director, and we have a physician assistant or a nurse practitioner that's with us 7 days a week that are rounding on our patients and ordering labs and really making sure that the patients are not, declining medically
Right.
and helping to move that
Right,
along. It's just
right,
super important.
right.
As you know, the acute care hospital stays have become a lot shorter.
Yes.
So patients are transitioning to rehab a lot quicker than
Right.
they used to. So it's really important to kind of stay on that medical.
What's your average length of stay for a rehab patient?
So the patients would stay in the acute care hospital for us on average 4 or 5 days. They transition to inpatient rehab, which is BTAR, and they would stay with us anywhere from 10 days to 2 weeks.
Okay.
If they've suffered a stroke or a spinal cord injury or a trauma, that time could be extended to 3 weeks and even up to a month.
Okay.
Yeah.
And if I remember correctly, they all had beautiful private rooms.
Yes.
Uh-huh.
Yeah, so our inpatient...
Like home. I mean, they're made to look like home.
Yeah. Our rehab program, we're really proud that we are one of the only rehab facilities in Eastern North Carolina that has all private rooms. And we actually just finished about $350,000 facelift of all of our patient rooms. So
Oh, wow.
we really took, as you know, 25 years of being a hospital.
Yeah.
Just like at home, things will
That's right.
have wear and tear.
That's right.
And we just did a lot of refreshing for our rooms and new wall coverings, and we updated the televisions, updated the bathroom. So the rooms really are beautiful.
I'm gonna
now.
have to come over and check it
Yes,
out again.
we would love to-
Yeah,
we'd love to
yeah,
tour you for sure.
Yeah, and I guess somebody else is gonna talk about like the pool therapy and all that, is that right?
Yes,
Yeah.
that's right. Yeah.
Yeah, so,
Yeah, I think some of the unique things that we've talked about are just really being spacious. If you were to come to our facility, you see really great access to outdoors. There's a lot of
Yes,
windows. We have a
yes.
dedicated therapy garden that has different level surfaces for patients to
Mm-hmm.
negotiate, and the gym at the rehab center it's just a really beautiful area
Right.
to receive care.
Aesthetically, it's really beautiful.
It
And,
is,
You know, you
yes.
can look outside, like you said,
Yeah.
lots of windows.
Yeah.
And of course, I'm all about gardens and I'm all about flowers and trees. So
Yeah.
it's pretty nice. Well, it's time for our first break. So when we come back, we're going to talk more about the Bryant T. Aldridge Rehab Center. So don't go away. Hang on.
It was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. I said, any surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
Hello, welcome back. Look, I got rid of a man and got me 2 women. Isn't that awesome? So this is more of staff at Bryant T. Aldridge Rehab. We have Stephanie, who's the nurse referral liaison, and we have Elizabeth, who's the nurse manager. Both jobs that I would have done the liaison job, but the nurse manager, no, I don't. I'm not cut out for that, Elizabeth. You gotta have a special. I don't know. You just have to have that gifting. I don't have that gifting. So, Stephanie, we're going to start with you. Tell me what you do. What is a referral liaison?
So I'm an admissions nurse, pretty
Okay,
much. So
okay.
I'm the one who gets the referrals from different hospitals and do the chart reviews and look at patients and decide whether they're, a good candidate for acute rehab.
Right. When I worked at case management at Nash, that was my last job before I left. And so it was Terry Glover at that day, and I'd call and say, I got patient X in room 5.
Right.
And so then I guess you probably do a lot of computer work first to kind of,
Yes.
figure out if they're even qualified. What would be some things that would disqualify the patient?
Well, we rely on the therapy recommendations pretty
Okay,
heavily.
okay.
The therapists in the hospital do evaluations of the patients, and they look at all sorts of things, the diagnosis, the patient's prior level of function, and make a recommendation based on that and what they think they can tolerate, motivation, participation, that kind of thing.
Okay.
So we rely on that, and then we look at support at home. That prior level of function, like I mentioned, if someone was very active and independent, then that would make them a good candidate.
Yeah, you want them to get back to that point, don't you?
Right. And then support at home, and we look at really everything.
And I think Brian mentioned they have to do at least 3 hours of
Yes.
like physical therapy a day, and that can be pretty grueling.
Yeah, we have physical
Those-
therapy, occupational therapy, and speech therapy.
Okay.
So if they need all 3, they would get an hour of each. And if they don't need speech therapy, then they would get an hour and a half each of PT and OT. But it is 3 hours of therapy a day, 5 to 7 days a week. So.
Yeah. So do you get to interact with the patient some too, or once you've said yay or nay, you're kind of out of it and on to the next patient group?
Well, interacting with the patients kind of comes up front before we decide if they're,
Okay.
that's in the process. So we do the chart review, but then all the patients that are at Nash, which are about 50% of our admissions come from Nash, I meet with those patients in person. So I go over to the hospital and meet with the patients and their families at the bedside. Kind of talk about rehab, talk about the therapy recommendations, let them know, what it involves, and tell them a little bit about the facility if they don't already know.
Right.
And that's, kind of upfront.
And I don't know the answer to this, so I'm just going to ask. So, like, I'm there and my husband wants to take me. Does he have the ability to go and look at the facility and say, oh, that's someplace I want my wife to go? Or
Yes, we do tours if families are interested in coming to see the facility. A lot of times, right when I'm in the room with them, they ask if they can come, and then we just set up a time that they can come, and I'll walk them around and give them a tour.
Because it's such a beautiful facility.
It really is.
I know.
It is.
I know. It's so aesthetically pleasing. So, and so patients are referred only by the hospital, or how are patients referred?
So we get referrals from case managers at different hospitals. So as I mentioned before, about half of them come from Nash, but we get referrals from Roanoke Rapids and Tarboro, Wilson, Goldsboro.
Goldsboro, really?
Yeah.
Wow.
And Raleigh and Greenville. So
Okay.
we get them from.
I've had some as far as Virginia, like.
Really?
Yeah, people who live up in the northern part of North Carolina sometimes end up at those trauma centers in Virginia. May get shipped there from Halifax, or so we'll get referrals because
So
they want to come
wanna
back closer
back
to home.
Yeah. All right. So how do you all engage with the patients and the families? Is there a time when they're, and maybe you need to answer this a little bit, I don't know, but is there a time when they're drawing close to their time to go home? Does the family come and see the progress, and do the therapists say, they need this or that? How does all that work?
Well, they are open, families are open to come anytime, to visit. And we do set up like a home training when it's close to discharge, so that families come in and they see the progress and see, what they'll need help with when they do get home. So we do set up, family training right before discharge. And we also have team meetings once a week so that family can come in, and all the disciplines will be in the room, and they'll talk to the family about how their, family member is doing with all the therapists. And
so how many nurses do you have? You have, let's say you're full, I think it was 23 beds that Brian said. So how many nurses, how many nurse to patient ratio,
Well, the way our building is set up, we have pods. Yeah. So pod 1 has 5 beds, and the other 3 pods have 6.
Okay.
So it's kind of a 5 to 6 ratio.
And one nurse for those, okay.
Yes.
Because they're somewhat independent at that point when they come to you, so. And then, of course, you've got aides if they need assistance going to the bathroom or whatever.
We do.
And do they have showers in their rooms?
They do. All of our rooms are private rooms.
Right.
With the really nice sized
I
bathrooms.
know. I remember it was, it's kind of like being home, It really it is.
Yes.
So, which is, I think, part of the whole concept of the
Yeah, we do try
rehab
to kind
hospital.
of create like a family environment there.
Right. So what makes Bryant T. Aldridge so unique? Why do people want to come to your hospital and not go? Well, for one thing, there aren't many of them, so Brian told me.
Right.
But what makes you all so special?
Well, I think she touched on part of that. Our facility is it's very beautiful, and all the rooms are private, and that's important to a lot of people. At this critical time when they're at maybe one of the hardest times in their life, we see patients with strokes and brain injuries, spinal cord injuries, and they're there for rehab, and they really want that privacy. So I think the private rooms are really important, and we just have a really great interdisciplinary team, with the therapy staff, the nursing staff, the management. It's just, and I think we have a great reputation in the community. So.
I know you do.
Yeah.
At least you did when I worked there. I haven't been there for several years now. I think Brian asked me how long I've been gone from the hospital, and I think it's 14 years, 13 or 14 years. I left there and went to be a nurse practitioner. So I was at RN when I was there. So.
Congratulations.
So thanks. Yeah, that was but anyway, so what kind of feedback do you get from your patients? Do they come back? I know
A lot of them do come back and visit us,
Uh-huh.
and it's always really enjoyable. You know, they come to see their favorite therapist or their favorite
Right,
nurses, and they
right.
just want to say, you know, thank you. We still have patients that send gifts just, you know, because they are just so happy at, you know, what the care they got there. But we have press Gamey, so they get a survey when they go home to let us know how we did. And we also do 90-day phone calls. So we want to make sure that they're doing, you know, once they get home, how are they doing to maintain what they learned there. So
That's awesome. Keep up with them. People
Yes.
like to be cared about.
Yes.
People like
They do.
to have that follow-up, you know. Everybody needs a pat on their back.
Yes.
Everybody does.
So some of them come back just to visit after they get home, and
Oh,
then
really?
some of them come back, you know, or a family member comes back because they say, "Oh, well, my brother was there and he had a great experience, and so I'd really like my mom to come." And so we see a lot of, you know, of that too.
Well, that's awesome. You know, that tells you something. I'm doing something right.
Yeah.
If their brother wants mom to come. So let's talk about the dreaded, I hate this subject more than anything, insurance.
So some insurance companies do require pre-authorization. So if that's the case, then that's something that I do. Once
is
I
it?
start the process, have to send clinical information to the insurance companies and wait for the authorization or the denial, because that happens too sometimes. So it's just part of the process.
But as a whole, I know that everything is individualized, but as a whole, Medicare pays, Medicaid pays.
Right. And then some of the Advantage plans, like these Medicare Advantage plans, they do require pre-authorization. And of course, we get commercial plans as well, and they also require pre-authorization.
Yeah, because unfortunately, you have 40-year-olds that are having strokes.
Sure do.
I just saw a patient of mine today, and she had an ischemic stroke. I don't think she went over there. I think she was able to go home. But you know, you think about that. Our world is so stressful, and we need to learn how to live in this. And I'm not doing real well in that in that department. I don't know about the rest of. Oh, there's Lee. I tell everybody Lee gives me the finger because they'll go. Anyway, it's time for our next break. So thank you, Stephanie. Thank you, Elizabeth. It's been a pleasure to meet you and chat with you. Thanks so much for all you do for our community.
Thank you.
We'll be back after just a couple words from our sponsor. Don't go away.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough. I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't arise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
Welcome back. This is the fastest show ever, y'all. I've never had so many guests in such a short time. I love it. This is wonderful. I'm going to make the hospital send me all sorts of folks like this. This is great. So this is Here's to Your Good Health. Welcome. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center, and I'm the owner of the Essential Health Medi-Spa. So now we have stroke care that is going on over at the Bryant T. Aldridge Rehab Center. And so we have Lauren Bunn. Welcome, Lauren.
Thank you.
And we have Tabitha Jackson. Lauren is the rehabilitation nurse assistant manager, and Tabitha is a case manager and a licensed medical social worker. So they've got lots of letters behind their name. But anyway, so all right, Lauren, let's start with you. What is your role? What do you do?
I'm the assistant nurse manager at BTAR, and I was a floor nurse at BTAR since 2016, so I've only been in this role for about a year.
Okay.
And I just oversee the daily patient care and the nurses that are at BTAR.
Okay, all right, that's good. And Tabitha, a licensed medical social worker, that's a big mouthful.
Yeah. Yes, I'm a licensed clinical social worker specializing in the medical part of it, obviously at BTAR. I have been there since 2008. And I basically do the case management, which means discharge planning, getting people ready to go home, and then also counseling for people who are having trouble adjusting to their illness.
Yeah, let's talk about that for a minute. I'm going to put you on the spot
Okay.
here. But I think it's really important
It is.
because if you have a stroke, you know, you've got some pretty major deficits that they can come back, and a lot of times they do. But how do you and they've got to have a lot of depression. So how do you help with that? How do you deal with that with the patients?
Yeah, so I think that is one of the great things about BTAR is that we do offer that. We don't just look at the person's physical deficits, but also how they might be internalizing that in their mental health and their emotional state, because we know that makes a big difference in how well you do in therapy. So I offer counseling in relation to how stroke affects your emotions. You know, 1 in 3 stroke patients will experience some depression at some point in their recovery, and we like to educate them about that so they understand that first of all, it's very normal and it's understandable, but there's also help out there. There's also things that you can engage yourself in, talk to your doctor about, to kind of to just approach that in a way that you know about it going home so that you're prepared.
Right. Because I think we all need hope, right?
Yes.
And so you're giving them that hope that this isn't forever.
Yeah.
It might be a deficit for right now, but it's going to get better. So that it's pretty awesome. So I know. Tell me about your education. Just what do you have to do to be a licensed clinical social worker?
So you have to have a master's degree in social work from an accredited school. I went to East Carolina University.
Go Pirates!
Go Pirates! And
although I'm really a Tar Heel. That's my undergrad.
Yeah,
I
we
know.
will.
That's my undergrad, but I got my nurse practitioner at ECU.
Yeah. So you have to have a master's degree, and then to get a license, you have to practice for 2 years under supervision of another counselor. So they really make sure that you're well prepared to address some of the really specific issues. And you do have to have a license in your state. So I'm licensed in North Carolina. Every state has a different licensure requirement, but you're able to do counseling and bill insurance and things like that with your license.
Okay, but you can't bill Medicare, or can you?
You can if you're in private practice.
You can, okay.
Yep.
Because I have trouble finding counselors, not that you would do this, but a lot of people will not take Medicare insurance.
Yeah, you have to be on the panel, but a licensed clinical social worker can bill Medicare if they choose to. Yeah.
Okay, that's the ticket,
Yes.
if they choose to. Well,
Yes.
I get that. And so the nurses, do they have some kind of specialized training? I mean, obviously, we've all been to nursing school, we've all passed boards, but is there a specialized portion for your nurses that they have more, detailed studies or?
Yes, ma'am. So it is, we only have RNs. We do not have any LPNs at BTAR. We work 12-hour shifts, 24/7. We're open 365 days a year, just like the regular hospital. You can have a 2-year degree from a community college, and you can also do your BSN You can do your MSN, and you can get a certification, which is a rehab certification, CRRN, where you go to a 3-day class that talks about the nursing care, the billing, just rehab as a whole, and then you take an exam for that, and you have to renew every 5 years.
And do you require that of all of your nurses?
We do not, but it is highly
Recommended.
encouraged. Yes, it is highly encouraged.
Yeah, yeah. I know, when I was there, and I've been gone a long time, but it was highly encouraged that you got your bachelor's degree.
Yeah.
Yes.
And so I did the whole thing. I did LPN, I did a nursing assistant, and LPN, RN, BSN. I got a master's in education,
Gotcha.
and then I got a nurse practitioner. So I've been up that educational ladder, and let me tell you, I never want to write another paper as long as I live.
Agreed. We understand.
Yes.
I know, right? I was cranking out a paper a week there for a while, I'll
Yeah.
tell you. It was bad. So let's talk about this stroke program. I'm pretty intrigued on that. Who wants to start or talk about that?
Where would you like to begin?
Well, how did it even come about? Whose brainchild was this to even have this kind of a program?
I think it's just part of the care of the stroke patient, because there are so many different, as Tabby spoke to earlier, things that the patients need and don't expect. And, it's a big change in their life. So we start with education. That's one of our big focuses. Not only do we educate the patients, we educate the families as well, the people that are going to go home and take care of them, make sure that they get their activities of daily living done, that they're safe doing those, they eat the proper foods that they won't choke on, they take their medications, monitor their blood pressures, that they can safely go out in the community, get in and out of their car, move around their house, use the bathroom. So we begin with education of the patient and the families and the caregivers.
So when you say education, you mean of their disease process?
Correct, of stroke, of where their stroke was. We have little packets. We start with what type of stroke you had. Was it embolic? Was it a bleed? Was it a hemorrhage?
So let's just talk about that. So
yeah.
what is an embolic stroke? I know what it is, but
Yes.
people watching don't know.
So an embolic stroke is a clot that restricts blood flow, that cuts off blood flow to the part of your brain where the stroke is. The bleed is a ruptured, vessel that causes a hemorrhage, and that's another form of stroke.
Right.
And so one of the parts of the stroke program, I think, as you were asking, is that we make sure that when the patients come, they and their families know that. Because like you
Right.
said, a lot of people don't know the difference. Some people will say, well, my grandpa had a stroke and it was different, and we can educate them on why. So that's part of it. What kind of stroke did you have? How does that affect you?
Right.
What kind of things can you look for as far as deficits?
Right, because depending upon where in the
Where,
brain it is,
correct, yeah.
is
Right.
where the deficit is.
Right.
Yes.
So grandpa might have had one on the left
Right.
side of the brain, and
Correct.
yours is on the right side of
Right.
the brain, which is a whole nother ballgame.
Right, and
So-
it's important to know. So I think, as she was saying, the education part of the stroke program is very important. We also really integrate families into, that's part of the stroke program, so we offer family training. So we don't just call you and say, hey, your mom's going home tomorrow. We call you and say, hey, your mom's going home Friday. Can you come in? Can you go to therapy with her? Can we get your input to see how you feel like she's doing, questions you might have? So we really incorporate not just the patient, but their whole support system.
Right. How can we make you all comfortable as a
Right,
whole?
right.
And that we are here, we get calls all the time, hey, we're home, this is Dad's medicine, what is this for? We have the paper, but what is he taking this for? We talk about modifiable and non-modifiable risk factors, modifiable being the ones that you can change, that you can control, non-modifiable such as heredity, disease processes, things that you can't change. Modifiable would be diet, smoking, alcohol use, lack of activity, things like that, that you can help prevent strokes.
And so do people have to continue like maybe some outpatient physical therapy when they go
Yes.
home, or in home if they can't drive for
Most
whatever
of our
reason?
patients,
yeah.
So they continue with physical therapy still
Yes.
out in the community as well?
Right, and that's part of the community reentry part of the stroke program, is that we don't just discharge you, we discharge you hopefully set up for success, so you have more
Yeah, right.
therapy, when your doctor's appointments are, you have a continuum of care, and it just doesn't end when you leave us.
Yeah, yeah. Yeah, that's so important. And,
It is.
the education piece is, people don't know. They just,
Right.
we in the healthcare profession, at least I know I do this. I'll be using words and they'll look at me quizzically and wait, let me back up. Let me talk
Right.
to you on your level.
Yeah.
Not that it's a bad level, it's just that I have more education in that. If you don't know, you don't know.
Yeah, and we see this every day. So
Right.
we sometimes become displaced from that people don't know. But our program really takes that into consideration. We want you to know what you're dealing
Right.
with when it's time to leave.
I think knowledge is power, and the more they know about themselves, and the more they know how to take everything, the better off everybody's going to be. The patient, the family, brothers, sisters, aunts, uncles,
Okay.
and so you have a stroke support group. Tell me about that.
We do. So that's kind of my baby.
Oh, that's your baby.
I did not start the group. The social worker that trained me actually started the group, but that group has been in existence almost as long as BTAR has been open.
Oh, really?
Probably
Okay.
at least 20 years, and I have some members that have been coming the whole 20 years.
Oh, wow.
So I think that's really powerful. But the stroke support group is just a place that people can come after they've gone home to kind of sit with people that know what they've been through, to share their stories, to share tips and tricks on things they've done. And I think just a place to come to know, like, you have people that have been through the same thing that you have been through, and you're able to be comfortable sharing how you feel. Because sometimes when people go home, they go back, everybody goes back to normal life, but your life is not normal. And it's hard sometimes for everybody around you to understand how you're coping with things.
Right.
So coming to the group is just a great place to be able to just be with people that are like you, that have experienced what you've experienced.
And I think, the whole thing is support.
Yes.
So, when you've gone through something, you need somebody that has been there, that
Yes.
we all need, and in whatever we go down the
Exactly.
paths of life that brings us, it's always nice if you can talk to somebody who's been
Yes.
in those
You're not
shoes.
alone.
You're not alone.
Yes.
And that, again, that hope that we all need. So.
Yes.
Well, you girls are just awesome. See, I told you it wasn't so bad. was it?
Thank you. Thanks.
All right, so I think we've about covered everything. So we're going to take our next break and give these girls, they get to go home. And I'm not sure who's coming next, but I got somebody else out there. When I came here tonight, there was a whole plethora of people. I went, whoa! I'm not used to all that. I do this show by myself sometimes, so to have all these
Yes.
guests is pretty awesome. I like it. All right, don't go away. We'll be right back with
Thank
more
you.
about
Thank you.
BTAR. Thanks so much, ladies. Hang on.
It was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. I said, any surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't arise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
Welcome back. This is Linda from Here's to Your Good Health. And now we've got speech therapy and physical therapy that we're going to talk to. These are also services over at the Bryant T. Aldridge Rehab Hospital. I was just telling Kia and Rob how much fun this show has been. Normally, a lot of times I do this by myself. So to have all these guests and all these disciplines, it's the best show ever. This is a Christmas present for me, y'all. So, all right, we're going to start with the pretty one. Kia McKibben is a speech therapist. So tell, what do you do? What is that? What is speech therapy?
So I do a few things. We focus on speech, right, hence the name, so the motor production of what we say. And we focus on language, which is kind of how our brain helps us communicate with people, how our brain sends messages for our expressive language, what we want to say, and how we communicate with people, what we understand from people. A good example is a lot of times after a stroke, people might experience some aphasia.
And tell people what that is.
Yeah, so aphasia is a communication disorder, so they may have trouble understanding what other people are saying, which is their receptive language, or expressing themselves. So it might be more mild, where sometimes they can't find the words they want to say, they feel like something's on the tip of their tongue, happens to the best of us, but could be more severe, where they might need we might work with them to find an alternative way of communicating.
Because it's very frustrating.
Yeah, absolutely. It's something we take for granted, is we can tell people things as simple as I'm thirsty, I need need to use the restroom, all that kind of stuff, or expressing our emotions.
And you can't always do that after a stroke.
Yeah, exactly.
So do you work primarily with stroke? I guess for speech and physical therapy is different. I mean, other problems other than, you could have a broken hip, for instance, but you don't really work with broken hips, I don't suppose.
I don't. Most of who I work with ends up being
Strokes.
speech. Stroke patients.
Yeah. How long have you been doing it, Kia?
About 1.5 years.
Okay.
So
Are you a pirate?
I'm not. I went to NC State, and then I went to UNC Greensboro. So mostly.
Okay, I didn't realize they had speech therapy at UNCG.
They do, yeah.
Apparently they do.
They don't at NC State, but they do at UNCG.
Yeah, I knew they did at State. Yeah, most of the therapists come either out of state or because physical therapy. There's 2 schools in North Carolina.
I couldn't give you the full number, but it's much more than 2 at this point.
Oh, okay. Yeah. At one point, it was only 2.
Okay.
I remember that. I was at Nash years and years ago. So, but there was maybe Greenville and like Western Carolina or something.
Okay. Yeah,
So-
that's increased significantly. So.
Good, because we need lots of physical therapists. I refer to physical therapy every day, what I do. So, not too much speech therapy, because that's more, I guess, the stroke and being inpatient and that kind of thing. I do some speech therapy referrals, but not many.
I think 2 other things that we work with a lot, especially with stroke patients, that other people may not realize, is with cognition, so thinking skills, getting back to managing things like medications or finances, things that take the thinking skills that can be impacted after a stroke, and then dysphagia, which is a swallowing disorder that people might experience. That's something that overlaps sometimes outside of stroke patients, because it could occur from a number of reasons. But if people have difficulty swallowing, that's something that we treat as well.
Yeah, so how do you treat that? What do you do?
Yeah, a big part of it is the evaluation component, so figuring out what's safe for people to eat, or if it's safe for someone to eat. We do that a couple of ways. We have some instrumental swallow studies, which is where we can watch people swallow on x-ray, or we have a little scope that we can put up people's nose. It's not as intense as it seems. It's very painless.
It doesn't sound fun at all.
It's quick and easy. And then from there we can tell where are things going when people swallow, and then depending on what the reason for the dysphagia or the swallowing disorder is, how severe it is, we give them recommendations on some thicker liquids if needed, or different textures for foods that might be needed, and then we treat it throughout therapy for some strengthening exercises.
Do y'all do outpatient? Do you work with outpatient too? Or
I don't.
You don't. Everything you do is inpatient. Okay.
Yeah.
All right. So, we already talked about your education. I'm trying to think if I have any more questions before I move on to Rob. So, Rob, you're a physical therapist. Tell us what that entails. What kind of educational process is that?
Yeah, certainly. So most of I think all of the physical therapy programs across the country at this point are 3-year graduate programs where you would receive a clinical doctorate in physical therapy by the end of that program.
Yeah, I remember, see, I'm old.
Uh,
I remember years ago when it was 2-year program,
Yep.
and then they had to go back and get that third year and get that doctorate, and there was a lot of fussing going on.
Yeah.
But I mean, nurse practitioner is that way too. I think the only medical discipline I know of that is not a doctorate is PA. I don't know that maybe they do. I'm not sure.
Yeah, I'm not sure about
Yeah,
the
nurse
physician
practitioner.
assistants, yeah.
Nurse practitioner is. I got grandfathered in. I don't. But anyway, so how long? Where did you go to school?
I'm a Tar Heel, so I went to UNC Chapel
Go
Hill.
Heels! I'm a Tar Heel. I'm not a Pirate. I got my nurse practitioner in Greenville. But my undergrad's in Chapel Hill. So you went to physical therapy school there too?
I did.
As well?
Yep.
Okay. Well, I see you got a blue shirt on. So we're getting a new football coach apparently.
That's what I hear.
And go the girls in soccer, huh?
Absolutely.
Yes,
That's
that's
great.
awesome. I was pretty excited about that. So there hasn't been a whole lot of sports that has been super in the last few years, but that's going to get better too.
Women's
Right?
soccer, yeah.
So what do you do, Rob, with your patients? So you do more than just, you only work with the stroke patients at
No,
BTAR?
so I think it's probably been mentioned to the listeners already that we do see a large number of patients who've had stroke at our rehab center. Certainly that's not all that we see. And so you mentioned, I think, a hip replacement,
Right.
which would kind of fall into the category of orthopedic procedures. So we do see a fair number of orthopedic patients in our population as well. We see a fair number of patients who've had back surgery and maybe having some complications after surgery where they need a little more intensive therapy before returning home. But whether it's a neurological patient, such as a stroke, or an orthopedic patient, physical therapy is always examining their patients through a lens of movement and mobility.
Right.
So really when I meet with patients, I'm looking to see what deficits of movement or mobility might they be struggling with that are preventing them from returning home and to their life, whether that be work or hobbies, time with family, loved ones, and so forth.
Yeah. So how long you been doing it?
This is year 8 for me.
Oh, okay, you're getting there, getting some.
Right.
Getting some. All right. So what's unique about BTAR for the two of you and what the services that you give? Kia, we'll start with you.
Yeah, what I really like about it, this is my first time working in inpatient rehab. I was very excited because there's a big, and they may have mentioned this before, but it's a nice open space. I think for me, just day to day, something that's so important is space, open windows, some sort of
Beauty.
access to the outside. I try, not today or recently, it's been pretty chilly, but I try
Or
to
rainy.
integrate the outdoors as best we can. We have a therapy garden, we have a big porch on the back, we have a pond. Sometimes we take patients fishing and try to integrate that into their goals.
You know what? That's awesome.
Yeah.
If you like fishing.
If you like fishing, yeah.
I'm not a fisher person, but
We try to keep it as functional for people or keep it within their interests as we can. So to me, I think the space that BTAR provides is really great. I mean, it's
a beautiful facility.
Yeah, it is, and a lot of patients comment on that, and I think that's, if you can feel comfortable in the space that you're healing in, that's a huge part. And there's space for everybody. The physical therapists and occupational therapists navigate throughout the building. They have the big therapy gym, and then sometimes with speech therapy, we need a little bit of a smaller, more secluded space, and I've got a little office for patients in there. And there's a transitional living suite. We can take people in and cook, to where I'm going to cook with somebody. So.
Oh, really? So that you can evaluate that and make sure they can.
Yep, getting through. It takes a lot of steps. A lot of steps that.
I
we
never
don't
would
think
have
about.
even. I'm in the business, and I've never thought about cooking. You
Right.
know, maybe because I don't want to cook. I don't know.
Yeah, exactly. Whether you
But
want to or
really,
not.
I know, right? 'Cause
Yeah.
I got to eat
Right.
healthy. I can't eat junk. So, but I mean, it's when you see, you say everyday living, but really, when you think about that, there are all those specifics.
All the little things.
Yeah.
Waking up in the morning, and what organization system do you have in place that can help you remember to, sometimes it can be even to brush your teeth, wash your face, brush your hair, take your medications. It's a lot of steps that kind of take for granted. They're part of your regular routine, but if you've had any sort of change, any sort of neurological change especially, or you've been out of your house for a long time, some sort of trauma that's happened from being in the hospital for a while,
Yeah.
takes some recovery to
Yeah.
get back to that.
Especially at this time of year when everybody wants to be home and be with their families, and that doesn't always happen for everybody.
Yeah, exactly.
So, and are there any unique features for physical therapy?
Yeah, I will echo Kia as well, because we have a lot of resources that we're grateful to have at BTAR. One of which, so if you think about movement, if we go back to movement, one of the first things we have to do is help patients get out of bed and get on their feet again, which for many people may be the first time in a long time. And someone who is deconditioned or weak enough, that becomes a heavy lift for a human caregiver. And so we have a lot of equipment at our disposal to help patients get back on their feet again, mechanical equipment that can help them stand, that actually allows the therapist to be a little more hands-off, where we can provide cueing and instruction without having to provide a lot of heavy physical assistance. We also, one piece of equipment which is fairly new is we have a car simulator. A lot of our patients, yes, a lot of our patients drive, and that's one of the first things they want to do when they get well.
Well, it gives them independence.
That's right. We're not putting them on the road, but we're letting them practice getting back in and out of the car again to show them that you can at least ride passenger for a while until you get back behind the wheel.
All right. So how long have you all had that?
I think they got it just before I started. I'm not sure they've had it a year yet, but I can't give you that. The facts on that.
Okay. So how often do you provide therapy? Daily, every other day, twice a day?
Regardless, it's Monday through Friday, it'll be 3 hours a day. And then kind of on the weekends, I like to try to give people a break, but we also ensure that people are getting sufficient amount of therapy. So people will get some free time on the weekends, let their family visit. It's a good time for that. But they will get 3 hours of therapy throughout the week.
Yeah. And if you can't do that, I mean, and that's tough. Physical therapy, they can be mean.
We do have that reputation.
But I mean, you do it because you want them to be better, and they have to exert that effort. So I mean, I get it, but I hear it a lot, especially with knee replacements. Oh, they will complain and fuss and just have a fit.
Trying to dispel that.
I know, that's right.
Mistruth.
That's right. All right. Well, I think are we done, Lee, or do we have a couple more minutes? Didn't he say 1 minute?
Yeah.
All right. All right. We're out of time. All right. Thanks so much for coming.
Thank you.
It's really nice to meet you all.
Nice to
It's
meet
been
you.
really great to do this. I'm going to get that hospital to send more of you guys like this. This is awesome. All right. This is it for us tonight. Thank you so much for watching, and we will see you next week with more Pierce Triggered Health. Good night.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough, and I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.